Good afternoon, bonjour. You're all welcome to the joint SAA, WHO, and UNICEF webinar on triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B, and synopsis of ICASA 2023 report. I'm here to take you through the housekeeping for the webinar. Thank you very much. So this webinar is going to be recorded. If you look at the base of the Zoom platform, you have the question and answer button where we
Please, can you put your mic nearer to you? We can't hear you properly.
Can you hear me now?
Yeah.
Okay. So if you look to the base of the Zoom platform, you have the question and answer button. Participants would be required to type in their questions during the Q&A by clicking on the Q&A button and typing in your questions. This session is going to be recorded, and all for those purposes, all the participants will remain on mute throughout the session. The session is also bilingual. So you go to the interpretation icon at the base of the Zoom platform. You click on more, you see interpretation. So if you are English, you don't have to switch the language, but if you are a Francophone, you go to interpretation, you click on French, and you'll be able to listen in French. During the Q&A, you have the panelists giving their questions and also the speakers being allowed to respond to the questions in the chat. Our moderator would also select the very pertinent questions to be answered by our panelists. Thank you very much. So without further ado, I wish to introduce to you our moderator for the session. We have Dr. Akudo Ipiezu, who is the team lead for HIV, tuberculosis, hepatitis, and STIs at the WHO Regional Office for Africa. Over to you, Dr. Ipiezu.
Thanks very much, Gordon. And ladies and gentlemen, good afternoon, good morning. A very warm welcome to this webinar organized by the Society for AIDS in Africa, SAA, in collaboration with the World Health Organization and UNICEF. As Gordon has already told us, it's a webinar focused on triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. And we'll also be hearing some of the outcomes of the last ICASA conference, ICASA 2023. And so it is my pleasure to welcome, to give us the welcome address and opening remarks, Honorable Dr. David Pagwesese Parinyatwa, the SAA President and President ICASA 2023. So we hand over to you, sir, for your opening remarks. Thank you very much.
Thank you so much. Thank you, moderator. I'm very, very excited as president of the Society for AIDS in Africa. This is a very important webinar. As you all know, elimination of mother-to-child transmission of HIV, of syphilis, and of hepatitis B are very key. And we want to welcome all the participants, including our esteemed speakers, and especially the Vice President of Society for AIDS in Africa, Professor Shakron, who is the elected representative of SAA in the Mediterranean and North Africa region. We really want to thank you and appreciate the efforts that you've made. The triple elimination is one of the key components to end AIDS in Africa. And we want to meet the target of 2030 as the MDGs stipulate. But also for the Africa region, we want to look at the Africa Union Agenda 2063. The MENA region is going to report to us on the triple elimination, which calls for this webinar, and especially to share what they have done in the MENA region, and also to hear what they are sharing with the Africa region and the world at large. The program is part of a strengthening of the SAA membership via the 5 regions of Africa. So this is particularly targeting also the MENA region so that our membership for SAA is boosted. We wish that you all enjoy this webinar and kindly make sure that you respond to this very short survey that will follow the webinar to show and to allow us to take consideration and to see what areas you need to consider in the future. So it is very important for us that you actually fill in this very, very short survey that we have sent. Let me conclude by informing you that the ICASA 2025, we have already started planning for it. The planning is really unfolding in a big way. And we are organizing the first ICASA 2025 steering committee meeting, which will be held in Accra on the 28th and 29th of November this year. And as you are aware that in December 2025, ICASA will be held in a country whom we're going to announce very soon. And it will be, the dates are already clear. It will be from the 3rd to the 8th of December 2025. But I want to thank specifically WHO and UNICEF for this partnership, which will propel the fight against HIV and AIDS, syphilis, and hepatitis. So thank you, and I hope that we will have a very fruitful discussion this afternoon. Thank you.
Thank you so much, Dr. Harry, for that very warm welcome, and of course, emphasizing the importance of triple elimination, not just for the Africa region, for the MENA region as well, and the unfolding plans for ICASA 2025. Thank you so much. So we'll move ahead now to the very first session of today's webinar, and it's my pleasure to welcome Luke Ahmad Bodia. Luke is the director of the International Conference of AIDS and STIs in Africa and coordinator of the Society for AIDS in Africa. Luke has over 20 years experience in high-level managerial positions, working with for-profit and non-profit organizations, not just in the Republic of Benin, but in Nigeria and Ghana as well. He's been part of the Society for AIDS in Africa since 2006 and has contributed immensely to revamping its governance systems, as well as played a unique role in terms of the advocacy that's been driven by the Society for AIDS in Africa. So welcome with me, Luke, who is going to be presenting to us on the Society for AIDS in Africa. Luke, over to you. Thank you.
Thank you so much, Dr. Akudo. Thank you for the introduction. Let me also thank all the participants here. I want to remind the participants that 1,698 people booked for this webinar, and I hope that we have all of them, as we continue unfolding this program. My role is very small, is just to share with you what ICASA means and what SAA means, because a lot of people know ICASA, the International Conference on HIV and STI in Africa, but they don't know Society for AIDS in Africa. In fact, Society for AIDS in Africa is the engine behind ICASA. As you know, before, when they started in the year 90, HIV/AIDS in Africa, they were hosting ICASA outside of the continent. They were hosting it in France, Belgium, and Italy, but few people came together and said, no, we cannot continue talking about HIV/AIDS in Africa outside of Africa. And then they started been together and discussing the issue with Dr. Peter Piot, then WHO director. And we noticed that some people like Professor Bessilman from Morocco, Professor Femi Soyinka from Nigeria, Professor Kaptoe Lazare from Cameroon, Professor Kandolu from Zambia, Professor Pierre Mpele from Congo, and Dr. Sam Kware, just to name few, they came together and organized Society for AIDS in Africa. And since then, they started organizing ICASA, the International Conference on HIV and STI in Africa. And it was done in Kinshasa in 1990. Since then, they rotated the power of hosting the conference, and also the SAA organized SAA governance system. And you can see through this slide how far we have 7 presidents so far, since Ben Silma in 1990 till our current president in this year, 2022 to 2025, the Honorable David Parentua Pabagwesi, former Minister of Health, which is the current president of Society for AIDS in Africa, and also the current president of ICASA, the International Conference on HIV and STI in Africa. Next slide. Talking about the Society for AIDS in Africa, it's good that you should know that Society for AIDS in Africa is a membership organization. And so far, we have more than 5,000 members across the region. You know, we have 5 regions in Africa. And one of the regions that we are today is the MENA region, where we have the Vice President, Professor Shakrun, who is the Vice President of Society for AIDS in Africa, and coming also from that part of the region. We have the core value of SAA. We have 7 core values, you know, as information sharing, independent. We are independent. We are not for profit, respect for human rights and dignity, accountability and achievement results, building partnership and establishing strong network, which we always do through our private, public and private partnership with the government and various key players in Africa, and cooperation beyond borders. Saying that, in addition to this principle, SAA is committed to the global effort to achieve the 95 treatment target by 2025, and ending AIDS as a public health threat by 2030, and ensuring the universal health coverage in Africa. Next slide. Talking about SAA activities, it's important that we should talk about, we have several activities, but our major activity here is ICASA, the International Conference on HIV in Africa. And since 1990, we have hosted 200 conferences in Africa. You know, sorry, we have hosted 22 conferences in Africa over 31st year. And I want to inform you that 2025 will be we witness the 35th anniversary of ICASA and SAA. You know, it means that 2025 ICASA, we don't know yet where it will be, probably in Ghana. We will host the 35th anniversary of ICASA. And you can see throughout this slide where we hosted ICASA, the 22 ICASA, you know, throughout. But this year, we hope that we will be in West Africa, otherwise in one part of Africa too. Next slide. And ICASA, you know, is not only for grassroots, it's also for the leadership. It's the ICASA that compiled the leadership in Africa, you know, to stand stronger and also advocate for the end of HIV in our end. And saying that you can notice that most of the leadership across the globe, you know, attended ICASA. For example, in 2008, we have His Excellency the President Wade in Senegal, you know, who was attending ICASA. You can also notice that in 2011, we have the father of PEPFAR. We used to call him the father of PEPFAR, is the President George W. Bush, who attended ICASA in 2011. You know, and the last ICASA that we hosted was in Zimbabwe last year, where we were very happy to host 2 presidents, the president of the host country and also the president of Mozambique, His Excellency Felipe Nuansi. He was there to support the host country president. You can see the high level meeting that ICASA is, you know, to commit to the higher level leadership. Next slide. And it's important to know how we host ICASA, because a lot of people don't know how ICASA has been hosted. You know that to host ICASA is through a call for bid. You know, the Society for AIDS in Africa send a bid out, and you as a member of SAA, whatever you are, you can call your government to ask them to bid for ICASA. And bidding for ICASA, they can send the bid, whatever they are. And then when they send the bid they pass through the member. We have more than 5,000 people. You know, the 5,000 members, they do scrutinize the bid and vote for 2 countries. After the voting for the members, we do the assessment visit for the 2 countries. And then we send the report to the board, and the board now scrutinize the report and do what they call the country, the host country nomination, you know, by the board. The board vote for the host country. Out of the 2, they vote for 1 country. And after voting for the 1 country, we discuss with the government to sign an MOU. The MOU clarify very clearly the support and the task for everyone, both the host country and Society for East Africa, and the third party that are the various stakeholders in the continent. And then after the signature of the MOU, we do contact directly what we call the announcement of the international community. And this announcement, we are waiting for this announcement for ICASA 2025. This is why so far we did not announce the host country. We are now at the last stage to announce the host country for ICASA 2025, and we are sure that it will be done soon. Next slide. Impact on the host country of ICASA. ICASA, you know, is the largest HIV conference in Africa. It's not only HIV, TB, malaria, and also strengthening the health system in Africa. And in terms of impact, we put just 6 points: social, cultural impact, academic impact, economic impact, visibility of the host country, impact on the health system, and the psychic and income, positive and psychological, emotional, or benefit of people that host ICASA. Talking about the impact, is good that we should also inform you or remind you that it was at ICASA 1997 that the president of France, Jacques Chirac, announced that the ARV in Africa should be free. And since that moment, the ARV is free in Africa, and France supported strongly the Global Fund and all the other stakeholders, you know, to push low cost or free cost for HIV in our continent. It's also important to notice that one of the benefits of ICASA is that since 2001, when the African Union said that at least 15% of the budget should go for health, in ICASA 2005 in Abuja, it was a reality, because then the President Obasanjo called all the stakeholders in Africa that really attention should be made so that the 50% of health should be given to our in all country budget. But so far, we did not reach that, and we hope that we continue to push by organizing ICASA so that all the countries in Africa can at least give 15% of the budget to health system in Africa. Next. In conclusion, ICASA is a Pan-African platform by excellence to advocate for the end of HIV by 2030, to call our respective government to provide universal healthcare coverage to all, to address the issue of NDCS, non-communicable diseases and emerging infections in Africa, and to strengthen our health system in Africa. I will conclude by saying that the next ICASA will be hosted in 2025, as my president has said, and plan is on the way to host the first committee meeting from 28 to 29 of November of this year. Thank you for your attendance, and we hope that we will reach you soon at ICASA 2025. Thank you.
Thanks very much, Luke. We thank you so much for providing us that very important background on the Society for AIDS in Africa. And of course, you know, some of the history around ICASA, and we look forward to marching forward with the Society for AIDS in Africa towards its 35th anniversary, which would happen next year as part of marking ICASA 2025. But I must also mention that one of the things that Luke has emphasized is the important role that ICASA plays as a platform for advocacy for HIV/AIDS for the region. Thanks very much, Luke. So we'll move on now to the next session, and let me remind all participants, please do drop your questions in the chat, And when it comes to the window to respond to those questions, all the speakers would have an opportunity to respond to questions that relate to their session. So join me as we move on to the very next session, which is going to be a progress report and roadmap on the triple elimination of HIV, syphilis, and hepatitis B in the Middle East and North African regions, Eastern Mediterranean region as well. And to present for us, we've got two presenters who would be co-presenting. We've got Shirley McPrabhu of UNICEF and Dr. Mohammed Shahid Jamil of WHO, who would present this progress report and roadmap to us. Shirley is the maternal, newborn, child and adolescent health and HIV, mental health and community health specialist at UNICEF in the Middle East and North African Regional Office, and has over 25 years of experience in multicultural environments, focusing on adolescent health and development, including HIV, sexual and reproductive health, mental health, and community health. As well, Dr. Mohammed Jamil is the focal point for HIV, hepatitis, and STIs for the WHO Eastern Mediterranean region, with the office based in Cairo, Egypt. He leads WHO's technical support to member states in that region. So join me as we turn over to our two presenters. Thank you, and over to you.
Thank you very much, Akudo. So from our end, I will start, but could you confirm if you see the slides well?
Yeah, we can see this.
Perfect.
Thank you.
Thank you very much. So good afternoon, good morning, good evening, everyone. First of all, I would just like to thank the organizers, Society for AIDS in Africa, for collaborating on this webinar with WHO and UNICEF, and I look forward to our ongoing continued collaboration in this area. So as Akudo said, so this presentation will be in two parts. So I will cover the first part where I will speak to give you an overview of EMTCTs, elimination of mother-to-child transmission or vertical transmission of HIV, hepatitis B, and syphilis. Orient you to some of the criteria and processes for validation by WHO. And then in the second part, my colleague Charlie will take you through the progress and roadmap for EMTCT for the region. So first, just to orient you to the epidemiology in the region. So these data are coming from the WHO Eastern Mediterranean region. It overlaps with MENA, but does not include all countries. So just to highlight that Algeria is not represented. And additionally, Pakistan, Afghanistan, and Iran are represented in these data. So for HIV, in 2023, there were an estimated 530,000 people living with HIV. In our region, we have a growing epidemic, particularly among key populations. So we have seen significant increase in the number of new HIV infections since 2010, so 132% increase, which leads to also increasing number of deaths related to HIV. So really a growing epidemic in key populations. But when we look at the coverage indicators, so you see our region is unfortunately the lowest across all regions in terms of coverage for the cascade. So only 38% of people living with HIV are diagnosed, 28% are on treatment, and 24% are virally suppressed. When we look at hepatitis and STIs, for hepatitis C, we have an estimated 12 million people living with chronic hepatitis C. This is highest in terms of absolute numbers anywhere globally. When we look at the coverage, we have 49% of people living with hepatitis C diagnosed and 35% treated. This is better than anywhere else, actually. And this is because of Egypt's massive scale-up of testing and treatment for hepatitis C. Hepatitis B, which is more of interest for the webinar today and this audience, we have an estimated 15 million people living with hepatitis B. But in terms of coverage, 15% are diagnosed and only 2% are receiving treatment. For STIs, the WHO estimates that there are annually 2.4 million syphilis infections. And then if you look at the graph at the top right, these are data coming from systematic reviews, really just to establish that we have a prevalence of STIs, which is on par with global averages. So, so we do have STIs in our region. Then just to orient you to the WHO triple elimination framework. So really globally, the commitment for elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B is high on the agenda and is a public health priority. WHO triple elimination initiative is guided by the global health sector strategies on HIV, viral hepatitis, and STIs leading up to 2030. And they provide a framework for a coordinated person-centered service delivery approach that addresses the life course of people who need that support, including women, newborn children, and their families. It also encourages integration through a simultaneous commitment to EMTCT of HIV, syphilis, and Hep B. So increasingly, we are encouraging and supporting countries to think about elimination in an integrated way for the three diseases. The success of triple elimination depends on the coordinated efforts of a range of stakeholders, including advocates, policymakers, healthcare providers, and the community. And really, the success, the communities, including women and girls living with HIV, they need to be at the center, including in the planning and delivery of interventions that are delivered in a non-judgmental, non-coercive way, and ensure that human rights of women, children, and families are protected. So why do we care about these three diseases? So really, the rationale is that these three diseases share a range, risk factors, outcomes, as well as interventions that are cross-cutting for these. So we know that all three are transmitted sexually sexually and vertically from infected mother to child. They can cause significant morbidity or mortality for the mother and newborn, including preterm delivery and stillbirth. These infections can remain asymptomatic or silent for a long period. So mothers can be infected without knowing that they are actually infected. So active case finding approaches are needed to identify these infections, which can be done during pregnancy and antenatal care. And then we have interventions that can prevent transmission from mother to child. So this slide gives an overview of the framework for implementation of triple elimination initiative. This is busy. I won't go into the details, but really you can see that we have 4 pillars for triple elimination. And the framework identifies target populations, essential services, and interventions for each of these. And then there are cross-cutting areas for implementation that we need to consider. So just to orient you to the 4 pillars, the first one is primary prevention of vertical transmission. And this includes testing, case-finding approaches, and primary prevention among non-pregnant and pregnant and breastfeeding women and girls. And this includes immunization for hepatitis B, of course. The second pillar is around linkages with sexual and reproductive health services and integration across these areas. So really focusing counseling, care, and support to provide linkages for women and girls living with HIV or hepatitis B or who are positive for syphilis. And then the third one focused on essential maternal EMTCT services. So this would include testing, prophylaxis, and treatment for women who have these any of these diseases. And then lastly, infant, children, and partner services. So really providing appropriate and timely testing, prevention, and treatment services, not only for the women, but their exposed or infected children, contacts, and partners. And then in terms of the cross-cutting areas at the bottom, these include health systems strengthening to provide more effective and accessible care, improving strategic information, providing leadership, meaningful community engagement, partnerships across a range of stakeholders, and thinking about cross-programmatic coordination and efficiencies. And then lastly, identifying any policy or structural barriers and ways to address them. So this is just an outline of the validation process for EMTCT that the countries need to embark when they feel that they are ready to be validated. So this is a 3-level process starting from the country at the national level. And really this is envisioned to be a country-led process where it starts with establishment of the national validation committees at the national level, which gather and collect information and prepare dossier for submission, which then get sent to the regional validation structure. So for the EMRO region, we have a regional validation committee that would then review those national validation committee reports and will send their recommendation to the Global Validation Advisory Committee, which is the final step. And once they are satisfied, they would recommend the Director General of WHO to issue the validation certificate. So this is sort of just an overview of the process that's involved. Here are the criteria for achieving triple elimination. These are clearly outlined in WHO guidelines that are available. But for each of the 3 disease areas, there are what we call the impact targets, which need to be met for at least 1 year, and then programmatic or service delivery targets, which need to have been met for at least 2 years. And so if I walk you through quickly, starting from HIV, so the impact target is to demonstrate that new pediatric HIV infection rate at the population is less than or equal to 50 cases per 100,000 live births. And the maternal to child transmission rate is less than 2% in non-breastfeeding populations, or less than 5% in breastfeeding populations. And then for programmatic indicators, this would include ANC visit coverage of more than 95%, coverage of testing among women attending equal to more than 95%, and ART coverage among women who are diagnosed HIV positive to be more than 95%. And then for syphilis, the criteria is very similar, so I won't go through that. For hepatitis B, it's slightly different because for impact, we use hepatitis B surface antigen prevalence in under 5 years old as a proxy for incidence. So the criteria is that prevalence needs to be less than 0.1%. And then countries that have targeted birth dose instead of universal birth dose, they need to achieve the maternal to child transmission rate of less than or equal to 2%. And then there are coverage targets for hepatitis B birth dose and third dose, depending on whether the country is offering universal birth dose, that is birth dose to all children born, or in a more targeted way. And by birth dose, we mean that hepatitis B birth dose administered within 24 hours of birth, which is the most effective intervention to prevent transmission. Then in addition to these criteria, we have what we call foundational areas of validation, which support, which needs to be included as part of the application. And this is to make sure that the health system is set up to maintain those successes and for sustainability purposes. So these have to be demonstrated as well. So for example, for program and service delivery, this would include, having high quality public and private antenatal care available, which is also, equitable, accessible, acceptable, and affordable to the clients. For laboratory, this would, for example, include having systems for internal and external quality assurance, proficiency testing, a national laboratory policy, and a referral system and network of laboratories available. On the data side, having systems in place to capture both public and private data on service delivery and outcomes. And this is really important. I think the private sector component is really relevant in our region, where a big proportion of healthcare is provided in the private sector. And sometimes these data don't flow systematically through to the national systems. And then last but not the least, human rights, gender, and community engagement. And as I said earlier on, this is to make sure that services are implemented in ways which are sensitive to human rights principles and ensure gender equality supported by legal and policy framework. And I must say that the validation committees really put high emphasis on human rights and gender issues. So these need to be central from the beginning as we start the process at the national level. So I think this was my last slide. I will now hand over to my colleague Charlie Prabhu from UNICEF. And just to say that from here onward, I think that any data presented are inclusive of full MENA region and also Eastern Mediterranean region. So over to you, Charlie, and I'd be happy to advance as you direct me. Over.
Thank you so much, Dr. Jamil, and just want to again echo thanks to the Society for AIDS in Africa for this, having this webinar at this very critical time, and to allow us to share the findings from and the progress that we are making in the Middle East, North Africa, and the Eastern Mediterranean region. So continuing from what Dr. Jamil has started on the EMTCT efforts in the region, we want to, I would like to say that, this next part is on the progress report on roadmap that was undertaken, that was initiated in 2022 on the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. And it covered 23 countries across the Middle East, North Africa, and the Eastern Mediterranean region. And before I get into the next set of slides, I would like to kindly acknowledge Professor Chakron for his kind support to UNICEF and WHO, and for leading this effort on our behalf, and for conducting this assessment for us and to help us come up with these very important findings. Next slide, Dr. Jamil. Yes, so as both of us mentioned, we looked at the progress across the 23 countries in the region, and as you can see that that Oman is the only country that achieved elimination, as was certified for elimination of mother-to-child transmission of HIV and syphilis. And you can see in the next this slide, but as we go on to the next slides, you will also see the progress in the countries. So here again, we see that while there are countries that have close to achieved targets, and those that have very close to achieving the targets, but there are still gaps in the countries, and there are other set of countries that are far from achieving the targets. So we have the greater equal to 95%, 80 to 94.9%, and then the less than 80 target, as well as those countries that have no reported data. So if you look at the last two columns, you can see that there is still a long way for us to go, and there are still many countries that are far from achieving the targets. And also, Dr. Jamil mentioned about the data, the data and information systems. And here we see that there are even countries that are currently not reporting, and much progress needs to be made in this area. Next slide, please. Yeah. So again, capturing the last two slides, we will see that the countries were divided into three groups according to their capacities to achieve the targets. So you see this first set of countries in light green that have achieved or near achieving targets, mostly the Gulf countries in the region. And then you have the second group of countries, which include about 8 countries that are on track to achieve targets with some gaps, and then the last set of countries. And if you look at this group of countries in red highlight, you can see that many of these countries are also currently going through conflict or protracted crisis, and where we see that it's not just EMTCT. If you look at the other indicators, they are also lagging behind in the other indicators to achieve other indicators. So there's still so much that needs to be done, and which also points to us that it's not just EMTCT as part of this effort that we are speaking about, but really in the sense of strengthening systems, the health as well as the community systems, as well as the broader systems that we're talking about, which also go beyond just health, but also multi-sectoral, cross-sectoral collaboration. Next slide, please, Dr. Jamil. And wouldn't get into details, but Dr. Jamil already pointed out to these foundational requirements for EMTCT, the program and service delivery, data and information system, laboratory information system, as well as the community engagement, human rights, and gender equality. Next slide, please. So let's go into the first area, which is program service delivery. And across as we did this assessment, and as we saw, was the partial integration of services, especially into maternal, newborn, and child health. And if you look at those countries, not only globally, as well as Oman and MENA, we see that, they have a very strong maternal, newborn, and child health system, which has been the foundation for achieving elimination. And as part of the challenges again, we see that there were challenges with HIV case finding, pregnant women and their sexual partners from key and vulnerable populations. And here we're talking about migrant populations, refugee populations that include here. And this is a big challenge for us because what's happening currently in Sudan, where the health system is completely collapsed. And this is one of the key, this is even in the normal, in the regular, in the system, identifying case finding has been a big concern for us in the MENA region. And I'm sure we have lots to learn from the African continent, and then can learn from the experiences. And here we have also a high number of pregnant women presenting late at ANC, no data on strategies on how to reach the hard to reach pregnant women through facility-based or community-based efforts, and lack of male partner engagement in couples counseling and testing, and limited or no coordination between and standardization of services between public and private sectors. Next slide, please. And if you look at the data and information management, we see that there is very weak or fragmented data on PMTCT interventions, resulting in poor data quality, as well as weak reporting on indicators, very limited data on syphilis and hepatitis B testing and treatment prophylaxis, and absence of data collection reporting from private sector. And this is also, you see, as part of the health systems, and many of these countries within the health system, where the public health system has collapsed, you see that the private sector has been engaged. There's been a lot of the service delivery through the private sector. But again, one of the key issues is the reporting, as well as the whole process of harmonization between the public and the private of the indicators, as well as the whole process of data collection and reporting into the national system. Next slide, please. And on the laboratory system, again, there has been shortage of rapid test kits. There's also viral load cartridges for early infant diagnosis, weak supply chain. Syphilis and hepatitis B surface antigen rapid tests are not provided in all countries. And again, the whole issue of limited coordination with the private sector and the standardization of services between the public and the private sectors, as well as the reporting by the private sector. Next slide, please. And then if you look at this, the last area which we spoke about, and Dr. Jamil already mentioned the importance of this area, there is weak or limited community engagement in most of the countries, and lack of documentation of community-led models or approaches. And as we see globally, that this area has received a lot of traction to see how within collapsed systems, or when public health systems are not functioning, how do we really strongly rely on on the community-led models and approaches and how this area should be strengthened within the delivery of services between the primary healthcare as well as the community referral and systems and mechanisms. And we see that there's lack of funding for civil society organizations, CSOs, and community-based organizations, forcing them to cease their activities. And in MENA, especially in this region, given the cultural context, stigma and discrimination is a major issue that's, for people living with HIV to also disclose their status or even being recorded in the system. So many, the data that we have does not really show us what's happening within the system, and very limited access to adolescents to sexual reproductive health services and PMTCT interventions, parental consent for those under 18 to access services, to testing and prevention. Next slide, please. And so just as I end this part on this part, I'd like to mention that earlier this year, and with thanks to WHO for all the support and the collaboration, also to Penta team, that we organized this capacity building workshop in Muscat that brought together 11 countries in the Middle East and North Africa, as well as the Eastern Mediterranean countries. So we had this meeting in May, which looked at the progress and the roadmap. We launched this progress report that you see, as well as sharing of experiences from other countries. So we also developed some practical next steps, as well as the plan of action for triple elimination for the MENA and EMBRO region. Next slide, please. And just a quick photo here from the capacity building training. And again, next slide. So I hand it over to Dr. Jamil for the last two slides. And thank you once again. And back to you, Dr. Jamil.
Okay, thank you, Dr. Jamil.
We'll wrap up. I might just skip this slide in the interest of time and move to summary to just outline some key messages. So I think the regional assessment and the roadmap provides a good baseline for the region to assess progress going forward, but also to prioritize technical support and capacity building. As outlined, we have several countries that are in the pipeline and have expressed interest in moving forward with the validation of EMTCT, but other countries like Iran and Egypt also, currently undergoing through self-assessment to really take stock of their situation. The regional validation structures are established for countries to facilitate their processes. And then lastly, in terms of priorities, we are focusing our support to countries in the pipeline and the ones that will need some support to either achieve elimination or to kickstart their processes. And thank you very much for your attention, and also to acknowledge Dr. Shakroon's support in this work. So back to you, Chair Akudo.
Thank you. Thanks very much, Dr. Shirley and Jamil, for this presentation on the progress report and roadmap on triple elimination. And of course, for emphasizing the 4 pillars of the framework, some of the foundational requirements for path to elimination and validation of triple elimination for countries, and the results and findings of countries' work along the 4 foundational requirements for EMTCT. I believe that this is a subject that would attract quite a bit of interest, and we look forward to having questions and the responses to those when we have the opportunity for more discussion. So thanks very much again. And we move on now to the next session, and it's my pleasure to invite Professor Mohammed Shakroon, who is the SAA Vice President, to give us a quick 10-minute report on ICASA 2023. Professor Shakroon is a medical doctor and a specialist in infectious diseases. He is currently a hospital practitioner at the Fatuma Bogiba Teaching Hospital and university professor at the Medical School of Monastir in Tunisia. Professor Shakran is also a national and regional consultant on HIV and chair of the Tunisia CCM. It's my pleasure now to hand over to you, Professor Shakran. Thank you. Professor Shakran, if you're speaking, you're muted and we can't hear you.
Sorry, Chair. Thank you very much. I'm facing some difficulties to share my screen. If you have the presentation from your side, you can share it. I ask Gordon, if you have my presentation, please share it. Thank you so much. Thank you so much. You can put on full screen, please. Thank you. Good morning, good afternoon, good evening, everyone, where you are, and welcome to this webinar. I am pleased to share with you some feedback from the last ICASA 2023 that took place in Harare, in Zimbabwe, from 4th to 9th December 2023. Next slide, please. So about 10,000 participants attended this conference, and more than 8,000 delegates were registered, and around 1,600 attended virtually. So 2,000 of participants took place in community village activities, and more than 500 speakers contributed to this conference, with 2,600 abstracts submitted, with about 35% of acceptance rate. Delegates came from 105 countries, and almost 40% of participants came from 5 countries: Zimbabwe, Zambia, South Africa, Nigeria, and Kenya. About 49% of participants were men and 45 women, and just over 1% were transgender. Geographic distribution showed a large majority of attendees coming from the Africa continent and 6% from other continents. Next slide, please. So 61% of attendees were aged from 20 to 60 years, and 61% of participants were program managers, clinicians, social service providers, and activists. Next slide, please. ICASA 2023 was marked by a strong leadership commitment reflected by the presence of His Excellency the President of Zimbabwe and His Excellency the President of Mozambique. In addition, the first ladies of Zimbabwe hosted the first ladies of Mozambique, Nigeria, and Botswana, or their representative. And ICASA 2023 was a good opportunity to confirm their leadership and commitment to the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B in Africa, and to highlight Botswana's success in becoming the first high-burden country to be certified by the WHO in 2021 as having taken a major step toward elimination of mother-to-child transmission of HIV. Next slide, please. ICASA 2023 also showed a strong UN agency engagement reflected by the presence and the opening statements and the remarks of Ms. Winnie Binyamina, UNAIDS Executive Director, as well as the WHO Afro-Regional Director and UNFPA Executive Director. Next, please. The presence of community and key population was very visible, and and they spoke openly as usual. And the commitment and their activism were very strong and much appreciated. Next. Despite their low attendance, the youth pre-conference underscored the commitment of the Society for AIDS in Africa for the young people, especially adolescents and girls. Next. So following this conference, some key findings in specific areas should be highlighted. At epidemiologic level, the data highlighted the varying trends in HIV/AIDS prevalence and incidence across different regions of Africa. Southern Africa has seen a decline in new infection, while West and Central Africa continue to face major challenges due to socio-economic factors and systemic barriers. At the social determinant of health, several studies emphasized the critical role of social determinants such as poverty, gender inequality, and access to education in driving the HIV epidemic. And recommendation included integrating social support system with HIV prevention strategy. The COVID-19 pandemic significantly disrupted HIV services with a significant decline in HIV testing and treatment adherence. The dual burden of HIV and COVID-19 exacerbated vulnerabilities, particularly among key population and the elderly. Next. Regarding scientific session and research insights, cutting-edge research was presented, including developments in antiretroviral therapy and vaccine research. There were presentations on new biomedical tools, including the use of long-acting injectable pre-exposure prophylaxis and post-exposure prophylaxis and the dapivirine vaginal ring, which are expected to revolutionize HIV prevention. Next. About community and civil society engagement, community-based organizations have been at the forefront of the HIV response, particularly during the COVID-19 pandemic. Their role in service delivery, advocacy, and education has been critical in reaching marginalized population. Several HIV programs demonstrated resilience, particularly those that are community-led. Adoptions such as telehealth services and decentralized HIV testing have been successful in maintaining service delivery during the pandemic. And youth, the importance of involving youth and addressing gender disparities in the HIV response was highlighted, and programs targeting young women and girls were particularly noted for their impact in reducing new infection. Next. And I would like to finish about some key recommendations based on the lecture and the studies presented on the conference. The high-level meeting of ICASA 2023 resulted in several policy recommendations, including the need of increased funding of HIV programs and the targeted intervention, such as the African First Lady Initiative on triple elimination of mother-to-child transmission, and the integration of HIV services with the maternal and child health, as well as sexual and reproductive health. African leaders and policymakers made commitment to strengthen health system, improve access to care, and eliminate mother-to-child transmission of HIV, syphilis, and hepatitis B. There was a strong emphasis on the need of sustainable financing and political will to meet this commitment. And there is a strong call to integrate HIV services with other health services and to create a more holistic approach to healthcare, which could improve outcomes of people living with HIV. Next, please. And there was the need for sustained and increased funding for HIV program with a focus on ensuring that resources are allocated efficiently and reach the community most in need. And there is also the crucial need of for increasing domestic funding and the financing for health system by African governments in line with the Abuja Declaration. Funding for vaccine research and development in Africa by African governments is also key in combating emerging diseases such as Ebola and Mpox. Continuing to support and scale up a community-led initiative as they have proven effective in reaching vulnerable population, particularly during some crises as COVID-19 pandemic. And it could be also during this pandemic of Mpox. And the conference stresses the importance of addressing gender inequalities and focusing on youth in all their diversity in the HIV responses, recommending targeted interventions for these groups and marginalized vulnerable population. And thank you so much for your attention.
Thanks very much, Professor Shakron. Thanks so much for sharing with us the outcomes of ICASA 2023. For those of us who attended, it was quite an exciting moment for us, and as well sharing with us some of the key recommendations going forward. And I'm sure those have been very well noted for action across the various countries that we all represent, and of course organizations that we represent. And I know that this is by extension an invitation for us to start thinking of participation in ICASA 2025. Thank you so much. So we move on now to questions, a Q&A. We have about 10 minutes to go through a number of questions. So I'll invite our panelists. I'm going to read through the questions, and I would call the panelists to respond to the questions. And please, as briefly as possible, to enable us go through as many questions as possible. For now, the questions we have relate to the EMTCT presentation. So we would ask for Drs. Mohammed and Shirley to please respond to the questions, the following questions. You don't have to repeat the ones that you have already provided answers to in the chat box, as I noticed that some have already been responded to. So the first question, does hepatitis C affect children below 5 years? The second acknowledges the good presentation and the low testing of hepatitis C and hepatitis B, and is asking about the impact on this on, those that are on newborns. The next is a comment on the importance of disease awareness education, especially in communities, so requires no response. And very interesting question, how long can it take for validations? Someone else wants to know and is requesting a comment on the cost. How much does it potentially cost for such a program, an elimination program in the context of a low income country? And there's a question that relates to the availability of hepatitis B immune globulin to mothers, since their children are expected to receive vaccination within 12 to 24 hours of birth. There's also a question here around utilizing a test a rapid test kit, I believe, which can test for the 3 diseases simultaneously, maybe a bit like the HIV syphilis dual testing, but one which can test in addition for hepatitis, since we've already got for syphilis and HIV. I think I would pause here and get responses to those, and then we can take more questions. So over to you, Dr. Jamil, and then we'll go to Shirley. Thank you.
Thank you. I can take a round, and maybe I'll try to do like a rapid responses. I think there was a question on the consequences of Hep B and C, and whether Hep C can affect children. And I can lump them together. For Hep C, I think it really depends on epidemiology. I think where the epidemiology warrants in high burden settings, it's not a bad idea to include Hep C in the package of testing that's offered to ANC or pregnant women. I think the incentive is that we have a cure for hepatitis C. So for 12 to 24 weeks oral course, you can actually cure more than 95% of people who have chronic hepatitis C. But then in terms of efficiency of transmission from mother to child, it's really very high for hepatitis B. And the issue is that the reason we prioritize Hep B also is because we have very effective interventions that can prevent this transmission. Starting from the mother can be put on treatment during pregnancy if she's eligible and diagnosed. New WHO guidelines are more flexible and permissive in terms of who is eligible for receiving hepatitis B treatment. And then there's also pre-exposure, there's also the use of ARVs to prevent the transmission. So that can also be considered. And then, as I said in the presentation, hepatitis B bird dose vaccination is highly effective. But also one consideration is that the young children that acquire hepatitis B, they're more likely to advance to chronic hepatitis B stage. And the treatment at the moment is, there's no cure, so it has to be lifelong treatment like hepatitis, like HIV with antivirals to achieve viral suppression. So I think that's sort of a short answer. The process for validation, it's a great question. It varies country by country, but it could take several months. There's no, hard and fast timelines. It depends how good the quality of submission is. Sometimes the committees will have questions or clarifications for which we need to go back to the countries to seek additional information, which sometimes takes time, and also sometimes we need to do in-country assessment missions. So short answer is it varies. And I will pick the question on RDTs, the multiplex one. I think it's a really important one, and I know that there are tests that are in development to facilitate integrated testing in pregnancy. So combination of HIV, hepatitis B, and syphilis. So you get 3 results for 3 diseases with 1 specimen and 1 run of the test. Several manufacturers are working on it. And once the evidence becomes available, WHO will review in terms of, the evidence on performance, but also, acceptability, feasibility, resource needs as per our guidelines. So I think this is an area which is actively in development, and I'm hopeful that it will be available in the near future. I think for the community awareness part, I would maybe defer to Charlie to speak to that. And for the immunoglobulins, perhaps I would invite Professor Chakroun to come in as well as a clinician. So over from my side. Thank you.
Thanks very much. So we hand over to Shirley. Dr. Shirley, please.
Yeah, thank you, Dr. Akudo. And just couldn't agree more on the importance of disease awareness education, especially with regard to communities at risk. But again, the question is, how do we do this within the context of stigma and discrimination in our region? So that's been one of the things that we've been really looking at, saying, how do we integrate, rather than having HIV, the STIs as siloed interventions or vertical programs? How do we integrate this within the existing primary healthcare, the maternal newborn child, adolescent health platforms, and also within the community-based responses, so that this can be addressed as part of a broader system strengthening agenda, and also how do we reduce stigma and discrimination within the cultural context. So there's definitely good examples in countries in the region, and and for our country, both WHO and UNICEF, we will keep talking about it, and together with our country offices to also see how what are different strategies that can be employed to bring more awareness, education among us, and especially how do we reach those communities that cannot be reached through that cannot be reached, that can be reached through other methods, and rather than siloed diseased interventions. So I'll stop here and hand over to Dr. Chakra.
Thank you so much. What I have to add is about challenges what we faced when we developed this progress report about the lack of data reported on antenatal care visits, about also testing for the 3 diseases, and especially for hepatitis B. We have some data about HIV and few data about syphilis, and also about treatment. And despite there is global AIDS monitoring, many countries didn't report on this global AIDS monitoring report of UNAIDS. Regarding testing, as Dr. Jamil mentioned, we don't have yet triple test WHO pre-qualified. So what is recommended now is to use available rapid tests pre-qualified by WHO. These tests are dual test HIV syphilis rapid test, and also one single rapid test surface antigen for hepatitis B. So we have to use 2 tests, one dual test HIV syphilis and one for surface antigen right now, but it will be better to use a triple test for the 3 diseases in one test, and we can have 3 results. Thank you so much for Dr. Jamil and Dr. Ms. Shirley for the presentation, and also for the inputs. Thank you.
Okay, thank you so much to Professor Chakrun, Dr. Shirley, and Dr. Jamil for responding to those first set of questions. We've got more questions, but we have just about 9 minutes to get to the end of the session. So we will try to pick on a couple more questions as quickly as possible. And there's a question here about whether or not the problem of drug use is being taken into account in HIV transmission. The next is on the similarities between hepatitis B and C. Can we use determined test kit in testing HIV for a child between the age of 2 to 4? And the next is speaking to inclusivity. To what extent are people with disabilities being included in the processes? And I believe it is in relation to triple elimination. There's a question here about if anyone with hepatitis B can stop taking medicines after several years. Can people with hepatitis B stop medication after several years? There's another on validation, and is asking if you can explain more on validation. Does it mean that for the country to start implementation of triple elimination, you should go through validation? And there's one here about, and this is a comment, how we can ensure, how can we ensure that the promotion of human rights, gender equality, community engagement are effectively integrated into programs aimed at eliminating mother-to-child transmission of HIV, syphilis, and hepatitis B. Then there's one asking about what strategies have been adopted for capacity building. Right. Now, I'm struggling a little bit because we've got more questions here. I'm not sure how many we can take, but I will just read the rest of the questions, and then fingers crossed our panelists can do 30-second responses on each of them. So what is the early screening of newborns? Which syphilis tests can we use as countries to determine new infections, given that the rapid test kits we commonly use are also reactive even to previously treated clients? What is the biggest challenge, and what strategies have been used to effectively implement triple elimination program? And how many doses of penicillin are considered an adequate treatment for a pregnant woman with syphilis? As I hand over to the panelists, I think what it does appear to me is that there are some core aspects and in-depth conversations that we need to take forward, perhaps in a future webinar. So I hand over to you, Dr. Jamil, Dr. Shirley, and of course, Dr. Shakron. Thank you.
Dr. Akudo? Hello, Dr. Akudo? Please, may I?
Yes.
I just want to inform you that we have some questions in French, and I would like Professor Shakron to attend to them, because we have 2 or 3 questions in French, and they are very excellent questions. Thank you.
I will do. Thank you.
Yes, they have actually been interpreted, and they're included in the ones that I've just read out. Thanks for flagging them. Thank you.
So,
okay, so over to you. Yes.
Yeah. So if you allow me, I can maybe start, and I can respond to the questions related to drug use and inclusiveness, and then early infant diagnosis and the validation process quickly, and then the rest of the panel can maybe take others. And I really have to say that these are all great questions, and we apologize if we're not able to address it during the webinar. So I think, as I said, we do highlight considerations for populations that have either special needs or are somehow disadvantaged and have low access to services, and these would typically include key populations like sex workers, women who inject or use drugs, also migrants or displaced populations. So we need to sort of have service delivery approaches or models that are sensitive to their needs. So really, I think it's thanks for highlighting that. It's really central to the EMTCT efforts. Then for diagnosis in newborn, for children under the age of 18 months who have been exposed to HIV. So for example, if the mother is HIV positive, the recommendation is that until the age of 18 months, you follow the early infant diagnosis using NAT technology or PCR tests. So the recommendation is that you should test at 4 to 6 weeks of birth. You can add 1 additional test at birth. And then if the exposure is continuing through breastfeeding, it is recommended that you have another NAT test at 9 months. And then once the breastfeeding stops, 3 months after that, you need to have another test to confirm that the child is negative. And after the age of 18 months, rapid diagnostic test serology can be used to diagnose HIV in children as for other adults, because until the age of 18 months, maternal antibodies can survive. Then lastly, I think I would encourage people to maybe go to the WHO website, and there are a range of tools and guidance available on triple elimination guidelines, but also several tools and checklists. I think where the countries can start is the self-assessment checklist, which is a simplified tool which helps countries to start thinking about how they need to orient their program services and identify gaps that they need to fill in order to achieve validation. I think validation is not the end goal. The goal is how you prioritize and orient services for people in need. So I think use it as a tool to sort of reach your goals. So I think those were the main ones that I had picked.
Okay, thank you so much. I think in the interest of time, I would invite Professor Chakron to respond to some of those questions that came in French, and then go ahead to make the concluding remarks. Yeah, thank you.
Thank you so much. There were three questions in French. The first one is about early infant diagnosis, and Dr. Shamil mentioned that the diagnosis is based on nucleic acid testing. That means RNA, HIV, or PCR, according to WHO algorithm. The second question is about hepatitis B vaccine. So what is recommended is the use of early birth dose vaccine within 24 hours, the first 24 hours, and second, and after that, 2 or 3 at month 1, month 3, and month 6. And the last question is about the treatment of pregnant women tested positive for syphilis. What we use is the benzathine penicillin, 1 dose for early syphilis and 3 doses weekly, 3 doses for late syphilis. But what we are using now on rapid test is a treponemic test, so we cannot distinguish early syphilis from late syphilis. So we need to treat all pregnant women tested with rapid test and tested positive with 3 doses of benzathine penicillin. So it will be 2 million unit weekly during 3 weeks. Thank you.
Thank you so much. My apologies to all those who feel that their questions might not have been given in-depth responses because of time. I think we've taken note of the questions, and we should aim to have further conversations that will provide the opportunity for deeper conversation on those issues that have been highlighted. So let me hand back to you, Professor Chakron, for a 30-second closing remark. Thank you.
Thank you so much. And I hope that all participants enjoyed this webinar. And the objective of such a webinar is to share knowledge and best practices on HIV/AIDS from different regions of Africa. And the MENA region include the 7 African countries, and also from different parts of other regions. The objective is also to strengthen HIV response in Africa, and for this webinar, we chose a public health priority worldwide, the triple elimination of mother-to-child transmission. So I think I would like to thank SAA for the excellent initiative to organize this webinar on this public health priority, to thank all participants for their engagement and for their pertinent question, to thank also all speakers for the comprehensive presentation. I think that countries presented in this webinar can take advantage from triple elimination as to improve their service delivery, to strengthen data quality and information management, to improve laboratory quality, and to enhance human rights, gender equality, and community engagement. I think much progress needed to be made in the MENA region, but also in the African continents to achieve the targets. And we have some good practices in MENA region from Oman, and in the African region from Botswana and Namibia. So thanks again for all, and looking forward to the next webinar in early 2025.
Thank you so much, Prof. And as we bring this webinar to a close, I want to just acknowledge the request for learning from Oman's experience and potentially from the experience of other countries. So thank you. And it's my pleasure to really, on behalf of the Society for AIDS in Africa, WHO and UNICEF, who co-organized this, to say a very big thank you to all the participants for joining us in this webinar. And we look forward to future engagements with you and to taking up together some of the detailed discussions that you would like to hear more on. Thank you, and we wish you a very good morning, a very good afternoon, or a very good evening, depending on where you are. Thank you and bye.
Dr. Akudo, are you still there?
Yes.
Dr. Akudo, well
Yes.
done.
Thank you
Well
very
done.
much, Honorable Dr. David. Thank you. And thank
Yeah,
you
you
to
were
everyone.
very clear and very measured. Thank you so much.
Thank you, sir.
Okay. Look.
Hello, sir.
Hey, how are you?
I'm fine, sir. Yeah, I just want to, we forgot to inform them that people who will do the survey will have at least a 5% discount for ICASA 2025 registration. And also we are giving them free registration for online ICASA online program. Yeah.
So you'll need to put it on website then.
We send it to them.
Yeah, send it to them.
To all of them.
No, good. Well done. This was very, very good.
Thank you, sir. Yeah, we are having a very good speaker, and the moderator was powerful too.
The moderator was really good, yes.
Powerful. And we stick to time. We need to thank all our participants and our well-wishers also, because you know, they turn out very well. Normally 1,654 people was in attendance. However, throughout the meeting, we hosted more than 320 people, which is not too bad.
Which is not bad at all.
But, yeah.
Okay, good.
Okay, thank you, sir. Take care.
Right on.
Okay, thank you. Greetings to all over there. We are closing now the platform. I hope that.
I think do close it.
Yeah, okay, sir. Thank you.